A nerve is a connection between the central nervous system and the muscles. So the central nervous system is the brain and the spinal cord, but in order for the brain and spinal cord to connect to a muscle, so for the horse to be able to move a leg, a limb, the information has to get to the muscle. So that will be a peripheral nerve, it'll be a cell body in the spinal cord, an axon, so peripheral nerve, and then the junction between the nerve and the muscle, the neuromuscular junction. And that's very important because something like botulism will act on that junction, and then the nerve can't connect to the muscle and the horse becomes very weak. This is one of our teaching horses, and it's rather overweight, but should do the job. So to do a neurological examination, I go from one end of the horse to the other. So I'll start with the head, and the first thing to look at is just behavior of the horse. Does it have normal mentation? Is it bright, alert, responsive? This is a normal teaching horse. This is as excited as it gets, but if this was a 2-year-old stallion, I might think it was not normal, that it's too quiet. But I think this is normal for this horse. And also, is it standing there normally? Is its head position normal? Does it have a head tilt or a head turn? Are its legs in funny places? And this one looks fine to me. So I then start from one end of the nose and move towards the tail. And the first thing I do is to touch the mucosa of the nose for 2 reasons. One, I'm looking for facial sensation, cranial nerve 5. And it's also a good test of forebrain function. If you have a horse that's depressed because it's got liver disease or some encephalitis, very often they will not respond to this, even though cranial nerve 5 is working. It's just you need the forebrain to function to respond normally. Oh, come here. You just know what's going to happen. And this clearly is responding normally to this. But he's getting quite annoyed. So I go back and forth if there's any question to make sure there's no asymmetry. And the next thing is to look at the tongue. Is the tongue nice and strong? And is it clean? Horses with botulism very often will have a dirty tongue, a weak tongue and a dirty tongue, which shouldn't happen in a normal horse, and this guy's fine. Does he have normal symmetry of his nostrils? And they look symmetric. No, he is slightly asymmetric, but it's within normal limits. So some slight asymmetry. You see the right side is bigger than the left, but in this case that is normal. But it's worth noting. I suppose we break them up into spinal nerves, so nerves that come off the spinal cord, and cranial nerves that come off the brain. They really are and do very similar things. It's just that the spinal nerves come off the spinal cord. The cranial nerves, there's 12 of them, although the first 2 nerves, the olfactory nerve and the optic nerve, are not really peripheral nerves the way other nerves are. The optic nerve, well, both the optic and the olfactory are really part of the brain, but the olfactory nerve in a human is so small, the olfactory bulb is so small it looks like a nerve. In a horse and in a dog it doesn't, it looks like part of the brain because it's properly large. So there's really 10 proper cranial nerves, of which some are motor, so the facial nerve which moves the face, and the trigeminal nerve which moves the jaw, and some are sensory, and then some, like cranial nerve 8, control balance, so they're special. I then move on to the eyes, and the first thing we do is test for vision, and we do what's called a menace response. I menace the horse and look for the horse to blink. And I go all through the field of vision, and on the other side. And every once in a while I might remind it that I am threatening the horse. And this is responding normally. I then look for eye movement, so I move the horse's head back and forth and make sure I have fast and slow saccades. So if you maybe want to have a look at, focus in on the eyes. And I'll move. You see how there's a fast and a slow phase to the movement? And that's normal. And I would do that on both sides. You can see the fast and the slow phase, and the fast phase is in the direction of movement. It's the eye catching up with the head to keep the image stable. And the next thing I do is I stand in front of the horse, come on, and I lift the head up and make sure the eyes stay level. If there's an eye drop on one side, it implies there might be a balance problem on that side, a vestibular system problem. Yeah. We're looking for increased sclera on one side. If you see more white on one side than on the other, that implies that that eye is dropped. Yeah, that's nice and quiet. And it looks the same to me. He's looking around a bit. That's nice. But you haven't got increased sclera on one side. So he doesn't have what we call an eye drop. He doesn't seem to have a vestibular problem. And lastly, we would do pupillary light reflexes. Although this is too bright, this is not the right place to do it in. But I put my light in and look for the pupil to constrict. And then I move my light to the other side and look for pupil constriction on the other side. What I'm really doing is looking for what we call a direct and an indirect response. So when I put my light into this eye, it should constrict. That it's too bright here and my light isn't bright enough to do it. That's in the left eye. In the meantime, the right eye has also constricted a bit as an indirect response. But when I move my light from this side to the other side, I should see it constrict more. In humans and in small animals, for the indirect response, I put the light in one eye and look at the other eye. I can't do that in horses because the eyes are on the opposite sides of the horse. So this is a way around it. This does the same thing. So I go back and forth and make sure that the pupil constricts every time I do that, which seems to be working fine. Okay, then I make sure that there's good ear tone and eyelid tone. Make sure the eyes can close properly. There's no weakness. Looking for a facial nerve paresis, damage to the nerve that moves the face. And that's me done with the head. So now I move on to the rest of the body. And the first thing I do is I'll do what we call a slap test, a thoracolaryngeal test. So if we swap sides. So I palpate the horse's larynx, which in this chap's going to be quite tricky, but in a thin thoroughbred is much easier. And then I slap the withers, and I'm feeling for a slight flutter on the opposite side. It's probably a response to the horse sort of, grunting as it moves off of closing its larynx. And if I don't get a response on this left side, I might think perhaps this horse is a roarer, has laryngeal hemiplegia. But it's quite a long pathway, so it tests quite a lot of nervous system function. And then I do the other side. So if I slap on the right, I'm trying to feel something on the left. Oh, this actually works, amazing. I thought it might not, he's quite a thick pony, sometimes it doesn't work in those. And he works fine on both sides. If he responded on the right but not on the left and was a big horse, I would worry about laryngeal hemiplegia. So that slap test that I did, I'm slapping on the side of the withers, the information goes up the spinal cord, then it goes down the vagosympathetic trunk, vagus nerve, loops around the heart, and comes back up as the recurrent laryngeal nerve to innervate the larynx. So it's a really long pathway, and the roarers have a problem in that nerve, usually on the distal side, so the far side of the nerve degenerates up here. And then if I slap it there, they can't constrict the larynx. The next thing is looking for cutaneous sensation. So I'll go down the neck. I'm looking for a local response, a local skin twitch, and that's just an in and out response. But I also might get a little response in the face, a cervicofacial response. We're not sure what the pathway is, but it'll go into the spinal cord and to the brainstem and stimulate the facial nerve again. So let's see if we can do that. Okay. This is a nice local response. And now if you film, oh, I'm so sorry. If you now film his face. That's a nice cervicofacial response. It means this pathway, the dorsal root, the spinal cord, and the brainstem, and the facial nerve are all working.
So by poking his nerves on the neck, you make him twitch on the face?
Yes. We don't know what the pathway is exactly, but it'll involve the spinal cord and the brainstem and the facial nerve. So all those things have to work for this response. I then go on and do the same thing on his trunk. That's a slightly different pathway. Let's see if we can film it here. That's a much longer pathway, so rather than just going in and out the way it did on the neck, this is the dorsal root goes in, goes all the way up the spinal cord to about here, and comes back out in a long nerve. So if I have a spinal cord lesion, for example, here, the test will work up to about there, and then it'll stop working. The next thing I do is to look for normal dorsi and ventroflexion of the vertebra of the back. Let's see if we can do it. You see how he, I don't know if you want to call it, bends his back ventrally, and then as I go over the back, he'll bend it dorsally. If the horse is very ataxic, quite often it has problems standing back up again. I can tell in the stable if the horse is likely to have a problem. And then we move on to his tail, and make sure he's got good tail tone. If he's got a problem with his sacrum, either trauma or what they call HahnEquineNEX, quite often there won't be good tail tone. And make sure there's anal tone also, just that he can pucker his anus, which is fine. And again, that's looking for problems with the cauda equina, the sacral spinal cord segments. And that's what I do when the horse is standing still. And the next thing will be when the horse is moving. The first thing I do is I have the horse walked up and down, and I'm looking to see if he has a normal gait. Now the chances are he's here because he doesn't have a normal gait. So I'm trying to see, is the problem regular or is it irregular, consistent or inconsistent? If he's lame, he'll have a consistent problem with every step. But if he's inconsistent, maybe the horse is ataxic, which is a neurological problem where the horse isn't exactly sure where his legs are. So let's just walk him up and down, please. And that seems consistent. You can also hear it, that the footfall is consistent. Let's just do it once more. And I look at the front legs and the back legs. In some ways, I look at those separately. So what I'll do now is what we call a tail pull. While the horse is, well, in fact, we'll do it while he's standing and then while he's moving. If you just turn around. Stand square. And I'll pull on his tail just to look for muscle strength. Yeah, If this horse was weak, maybe because of botulism or something, I may well be able to pull him. The next thing I do is pull while he's moving, and horses that have a problem in their spinal cord, so the brain is not connecting properly with the nerves of the back legs, he then can't give the information, oh, I need to straighten that leg, someone's pulling on me. And these horses can be profoundly weak. These are often wobblers, young wobblers, that are big, strong horses, but as soon as you move them off, the head can't communicate with the back legs for them to extend their limbs. Let's just walk up slowly. A horse I saw recently. It's also the same sort of colour, but it's a very different horse. This horse has cervical vertebral malformation, so he has a spinal cord problem in the neck, and the brain can't communicate properly with the nerves in the limbs, and vice versa. And you can see that he is somewhat weak. I'm able to pull him over when he's moving away, and I'm hauling on his tail. I'll then take the horse and do some other manoeuvres. If you could just loiter. And horses can walk normally with very little of their brain needed. So I need to make things a little more complicated to try and accentuate problems. So I'm going to do some circles and some serpentines just to see if I can enforce some problems, some inconsistent movement or ataxia. And again, I will separately look at the front legs and the back legs, just to be sure that they're moving normally. So I start off holding the horse's head up a bit.
Why do you keep the head high?
It's just to change the visual input and to change the gravitational input. It's just to make things a little more complicated. A horse, you can practically cut its head off, and it'll walk in a straight line just fine. It's very automatic. There's lots of activity in the spinal cord that allows these horses to move. So you need to make things a little more difficult for them. And I'm just showing what happens when you raise the head and change visual input and gravitational input. This is another ataxic horse, and it's ataxic, so incoordinated in both the front limbs and the back limbs. So here it's walking relatively normally. But as soon as I put the head up, can you see that the horse starts to pace? So it's a 2-beat lateral gait all of a sudden. This is not normal in a British horse. This is not a standardbred. And as I'm moving him back and forth, you can see, ooh, how inconsistent the limbs are, and it's almost stumbling.
What causes that?
And again, this is another one that has a problem in the neck spinal cord, because of cervical vertebral malformation.
But how does that make the horse pace?
It's just changing input into the brain, and because the spinal cord is compromised, the horse can't sort it all out, and it changes the pacemaker. It changes the spinal cord pacemaker that allows a normal walk or a normal trot to happen. And these normal British horses that don't naturally pace will suddenly start moving the legs at the same time when they shouldn't be. Make the circle smaller and smaller and smaller, and really push the horse. And if the horse was ataxic, you would see him doing funny things, stepping on himself, the outside limb making big steps and little steps, and then I'll do that to the other side also. So again, I'll lift his head up, moving in a biggish circle. So there I'm doing the same thing again, largish circle with his head up, but can you see how the front legs are making biggish movements? And he makes mistakes. He's swiveling on the back legs there. He makes these funny movements with the outside of the back limb as it's moving around. And the front legs also big movements little while he's standing on himself. This horse has problems knowing where his legs are. And I think he realizes that and gets a bit stuck. But you can see it's inconsistent movement. That's very abnormal, and he's very ataxic both in the front legs and the back legs. Ooh. And I don't move them too hard, or they might even fall over.
And what was wrong with him?
Ooh. And you can see, this horse has cervical vertebral malformation. He's a wobbler. And this is a radiograph, an X-ray image of the horse that we examined earlier. And this is his head, and you can see the buckle from the head collar. This is the second cervical vertebra, the third and the fourth, so the tail is back here. And this space here is the space where the spinal cord lives. And this is misshapen in this horse. You can see that this roof here, it runs too far caudal. This is the third vertebra and this is the fourth vertebra, and this roof should stop here and is running all the way back here where the spinal cord, when that horse bends its neck, the spinal cord is impinged between the roof of the third vertebra and the body of the fourth vertebra. And what we do to diagnose it, we take a measurement, the width of the canal, which can be in the vertebra or between two vertebrae. We compare it to the width of the body of the vertebra. So if your X-ray plate is a bit further away from the neck and everything gets bigger, but that ratio stays the same, and this ratio here is too small. So that's where this horse's spinal cord got squashed. But this is another example of a more severe case. This is, I think, this is the second cervical vertebra again, the third and the fourth, and you can see how narrow this space is, and this poor spinal cord is completely squashed here between C3 and C4. And if you take an X-ray image at the same level, you can see again this extension of the dorsal arch here, caudal extension. This is malformed. You can see how there's a little angle here that shouldn't be. This horse was X-rayed in a neutral position, and in here is where the spinal cord got squashed. And these can be remarkably acute onset. This horse could have looked normal last week, or nearly normal, and then they've lost 1 too many nerve fibres running through there, and they become profoundly ataxic. And this is not salvageable even by surgery. This is too bad.
So every time the spinal cord gets sort of impinged,
yes, it
gets
squashes.
worse.
It gets more and more of these fibres are damaged. The next thing I do is to hold the head and the tail, and to see if I can feel the horse being weak on one side or the other. I'll try and pull the horse towards me. So I grab the tail, and again it comes to the torque, and see if I can move the horse around me. The point is that the horse is moving around me rather than the other way around. And then let go suddenly. And quite often, if they have a problem with their spinal cord, they will end up with their legs in very strange places. Now you can see again, he made some mistakes, but I could feel that he wasn't particularly weak either in his tail or in his front, either in his hind legs or his front legs. So I couldn't pull him towards me. Try it on the other side also. It is somewhat a matter of experience, because a young thoroughbred will feel quite different from this older big pony, but it's the same idea. And he corrects very quickly, so there's no problem there. Sometimes, if I'm concerned that there's a front leg problem, I might pick the leg up and hop the horse. I might be able to do it here. I usually do it somewhere a bit softer. Let's see if I do it. Rather like hopping a dog, just bigger. If I
really think there is a problem in the front legs. If I've already seen a problem, I don't do this in case the horse falls on top of me. Okay. And I might find a slope and walk the horse down the slope, again with a head up, again just to try and change inputs to make things more complicated. But this really is the regular exam.
Owners not infrequently will call their vet because their horse is behaving abnormally and they think the horse has a brain tumour. And it's one thing horses do not get. Almost without exception, they don't get brain tumours. Humans get brain tumours, dogs get brain tumours, horses do not. If they have a real behaviour problem, there's either something like a liver problem, or the horse is just badly behaved. It doesn't need to come to me. For example, if you have a problem in the brain, either through trauma or some problem with the body like liver disease or kidney disease, liver not uncommonly in horses, that might affect function of the whole nervous system, but particularly perhaps the forebrain. So the horse changes its behavior, it becomes dull, it might start head pressing, or for something like rabies it might become aggressive because that forebrain has been hurt. Or you can get problems with the brain stem, and that's where your cranial nerves come from. So you might have problems with the horse being able to move its face, or being able to close its jaw, or feeling the sensation to the nose, for example, which we were looking for before. Or you can have a problem just in the spinal cord, like the two cases we just saw, where the brain is fine, there's no problem with mentation, there's no problem with moving or feeling the face, the horse is acting normally, but the movement of the body is compromised in that the horse can't quite tell where the limbs are and can't send information from the brain back to the spinal cord to ask for a normal walk or a normal trot. You can also have problems with the balance system, which can be a problem in the inner ear, which is where the majority of the receptors for balance are. So this again is not uncommon when the horse falls backwards, which they do. You can sometimes break the petrous temporal bone, it's a very dense bone, but if you break it, in there is the inner ear that controls balance. And these horses can have profound balance problems. And if you have a 500 kilo horse that isn't quite sure where up or down is, it can make for a very exciting neurological examination. Same thing could happen if that area is affected in the brain, so you can have a problem in the neurons controlling the balance system. That luckily in Europe is much less common because we don't have the protozoa, particularly Sarcocystis neurona, that the Americans see, and they would have a lot more of the central vestibular problems. We see that much rarer in this country.